like in the bigger picture.
In the whole picture. Hi, welcome to Yours and Life, everyone. It's Christmas Eve.
Merry Christmas.
Merry Christmas. I don't know if we'll show this on Christmas Day or not. This is my dear friend, Dr. Rachel Pearl. Do you want to say hello?
Thank you, Daniel.
Yeah. Do you want to tell anyone or everyone what type of physician you are or anything about that stuff?
Sure.
Okay, go.
So I'm an emergency physician, which means I deal in the first 2 hours of any type of emergency. I work in an emergency department only. I don't have a private practice. And I take whatever comes through the door.
Is that pretty gnarly? I'm just going to go from that description. That sounds relatively intense.
Yeah, it can be very intense. It can also get boring just like anything else.
Oh, what gets boring about it?
Well, believe it or not, while people perceive certain situations as emergencies, they aren't necessarily what I would consider to be an emergency. So I'm trained to administer medications and do procedures and help people with medical conditions. But more often than not, I'm treating people with anxiety and depression and addiction and chronic illness. So that takes more time and more patience than I can afford when I'm at work in my particular circumstance.
So that's your professional life. Can we mention that you have a family?
You can mention that.
Can we mention that you're a mom?
I am a mom, yes. I have 3 boys.
Okay, so I just want to put that out there. ER, physician, mother of 3, dealing with this stuff. Just that's our baseline today.
I've got 3 really decent boys.
They're beautiful children, through and through, no question, top to bottom.
That part's easy. And an amazing husband.
Amazing husband. I have like a serious crush on her husband.
It's mutual.
So you said a lot of things already. I've heard that statistically 80% of all cardiac-related experiences that come into the ER are anxiety-related. They're not, you'll have to correct my language, cardiopulmonarily? How do you say it?
You mean 80% of people who have chest pain don't have a cardiac condition?
Yes.
Is that what you're trying to say?
Yes.
That they have non-specific chest pain?
Yes.
Well, that's what I was getting at before.
Okay.
So that's why my job can be a little mundane, because
it's real for them.
It's totally real for them. I know, but I have to get really present to be with somebody who's dealing with more of a psychic emergency.
Those are real.
You know how it takes,
I do.
It takes presence, and it's
presence.
not easy to gather presence when
you're at work.
It's a very chaotic environment, and I have to keep the flow going of people coming in and out. And
that's hard.
Yeah, it's hard to give all of that.
I'm sure you do great.
People need a lot. And they deserve a lot.
Well, it's so
not
curious
always the right place.
that people who feel like they're dying would go to see a stranger for comfort, right?
It is curious.
It's a curious thing that what people are looking for maybe is, if only, or perhaps a connection. And I'm sure you provide that, right?
100%.
You said addiction. Have you noticed, the rate of overdose in our country has, I don't even know how to talk about it mathematically. It's so exponentially higher than it was 10 years ago, much less 20. Have you seen an increase of the ramifications of drugs and overdose go up in your time?
Yes. Let me think how to answer that. I don't know if I personally see that many overdoses, or not necessarily life-threatening overdoses, but what I do see is a lot of addiction-related illness.
Oh, such as?
And just a high prevalence of drug use among all of us, from the very young to the very old, from all walks of life.
What are drug-related illnesses that you're thinking about?
Well, substance abuse can be self-medication, so their illness might be so-called mental illness, like depression or anxiety.
So-called? Wait, are they not depressed, or what do you mean?
Well, we're talking about illness, but I
Okay.
didn't say mental illness.
Okay,
so
okay.
mental illness is kind of what I'm talking about.
Okay.
And then, as a consequence of using drugs, yeah, of course, you can develop
Right.
long-term addictions and complications thereof, and infections and HIV, just as a consequence of poor decision-making and or what people need to do to get the drugs they want. Or
Yeah, right.
the environments they're hanging out
It's
with.
very tiered, the suffering.
You know this. Yeah.
I do. I appreciate the way you frame it, because we're at different sort of access points, if you want to call it that, to the results of this epidemic chaos that people have, both with drugs, their use of drugs, their sort of barbaric necessity to acquire drugs, what it does to their life, to their family, and then quite literally you deal with sort of the body element of if things actually happen.
Well, yeah, I mean, I'm not sure if you mean like if something bad happens to them physically.
Yes.
No, oftentimes they're coming into score.
Grimmer.
So there's what we call drug-seeking behavior.
Oh, yeah.
Which is feigning pain, or maybe there's pain, it's chronic pain, it's psychic pain.
That's tough, right? Chronic and psychic is different pain, yeah?
Well, it might be that somebody has a broken bone at some point in their life, and they're coming because of chronic pain from that broken bone, or from back pain, long-standing back pain, which is not something that's easy to look at and see, so you kind of have to give people the benefit of the doubt, but it's not my place to be prescribing narcotics for that. But I often get into a lot of conflict.
I bet. That hunger is deep for people.
Yeah, and pain is very subjective, and narcotics do help with pain, but not in the long term.
Yeah.
And create a lot of other problems. So, people come into score, and then people come in because they're suicidal, or they've expressed suicide to somebody, or they're having methamphetamine-induced psychosis, and they're running the streets naked.
Yeah.
We have a whole area for our psych patients like that, and most of them have some kind of dual diagnosis, like a drug issue, in addition to whatever mental illness is plaguing them in the ED that day.
The co-occurring situation. Yeah, absolutely. It's not, well, we're sort of softly navigating the reality that it's often not one thing. So the anxiety is a collection of a life experience that results in someone rushing to the ER, believing that they're dying, and needing some connection to sort of bring them back to their life, that they may have to deal with the other suffering. And drugs are often a result of a multitude of things. It's not just you take away the drug and the person is fine. So whether it happens through genetics or epigenetics or conditioning or chronic pain that they discover drugs, like these things sort of form this storm of just intense, aggravated, ongoing suffering.
Exactly. And so you're looking at this very complex case, or a patient, and
ecology.
I have maybe 10 minutes to spend with them. Half of that time is them telling me what they need, and the other 5 minutes I have to make the best use of, which is try to be empathic, maybe make a connection, and very lovingly say, tonight we're not going to fix all these things tonight, or
we're not going to fix all these things tonight. It's a beautiful thing to hear.
Not everybody thinks it's so beautiful.
Right. I wanted to talk to you about death, because you experience death or are near death often, and then we both have interest in hospice. I think your interest is maybe a little different than mine. Would you care to talk about that at all?
Yeah, I mean, I think my interest in hospice and taking care of people with terminal illness stems from a frustration from dealing with and taking care of patients who are at the end of life in the emergency department, because that's that's the last stop, but it's usually a very chaotic and sometimes unfulfilling interaction. So I'm always wanting to catch people a little bit earlier than when they are at death's door in the ER, and to have a more meaningful interaction and time to spend with them and potentially address some of the problems that we see when people come in at the end of life and haven't made any plans for the end of their life, or thought about what's going to happen at the end of their life, or thought about how our medical care may or may not serve them at the end of their life.
Yeah.
And so, one of my projects right now is to help physicians learn how to communicate better with patients at the end of life. And again, not like on the day that they're dying, but in the months leading up to a death that is anticipated.
And I imagine that this protocol that you're developing or working with would be useful for anyone to engage with anyone?
Everyone should engage with everyone about this.
Okay, cool. Well, I won't labor you with questions about death and dying.
No, it's okay.
I'm just curious about that space because you have the opportunity, the privilege to share the information of someone passing, often with the family, and I imagine that's a very potent experience to share that sort of life-changing information. Anything you can speak about on that?
Yeah, most of the death that I am there to witness has happened in the moments before a patient arrives to me. So someone who's in the process of being resuscitated, and we may or may not get this patient's life back, but I don't get a personal interaction with the patient, obviously. My most fulfilling interactions happen when somebody comes in at the end of their life, okay, maybe not conscious, and there's family there with them, and I have the opportunity to sit down for just a few moments and get to know the family members, to understand and help them decide how aggressive they want to be in trying to resuscitate this patient. So if you have a cancer patient and they're in the dying process and they're actively dying, and most of the time people panic, haven't been able to prepare, which is totally understandable.
It's a lot.
And expect that we're gonna, like on ER, on TV, we're gonna save this person's life, and they're gonna be talking to them the next morning with a little oxygen cannula. That's just not what it looks like.
It's not happening.
We're more often talking about somebody who's very brittle, very ill, very frail, and you're doing chest compressions, and you're putting tubes in them, and you're breaking ribs, and it can be very gruesome. And the quality of the life that you might save may be a very poor, a very low bar for by anybody's standards.
Question of what life actually is.
Right. So if you can get to the patient and their family before that happens and understand maybe what the patient's priorities, what their goals are in life, what their preferences are for care, and you get the whole family involved to understand exactly what this person wants at the end of their life, it's so much better.
Yeah,
right? I mean,
sure.
nobody wants to be connected to a million tubes and have somebody crushing their ribs in the last moments of their life.
No, I don't.
I mean, so we gotta make it clear to people that that's what it looks like oftentimes.
That's cool. That's beautiful work to do, right?
Yeah, so then, so that's the worst case scenario, but the best case, if I can get the family in and say, look, we can do these things, but it won't be pretty. And maybe we can look at ways in which we can make your loved one really comfortable. You can all be sitting around and you can talk about how much you love him or her and enjoy these final moments together, and we can put you in a room, you can put on music, and once I can connect to a family, if I can gain their trust,
Mm-hmm.
that is incredibly satisfying if they can agree that that looks better,
Mm-hmm.
and we can scale back the medical care
Mm-hmm.
and ramp up the like spiritual care,
The transition.
and
care.
the transition. That's really beautiful.
That's cool.
And and usually there are hugs and embraces,
Mm-hmm.
and that's like the best part.
It's more of a celebration.
It's more of a celebration.
Well, you're the coolest. Last thing I'll ask is, what do you think happens after we die?
Fuck if I know.
Well, thanks so much. Merry Christmas.
Happy holidays.